This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from Neurologia medico-chirurgica, published in 2026. The paper is titled, Full-Endoscopic Laminotomy is Effective for Lumbar Spinal Stenosis with Low-Grade Spondylolisthesis, a comparative cohort study.
This is a timely topic, Alara. For years, the to fuse or not to fuse debate in the context of degenerative spondylolisthesis has been a staple of our morbidity and mortality conferences and board exams. Traditionally, if you saw a slip, many surgeons reached for the screws. But as our techniques have evolved toward minimally invasive and now full endoscopic approaches, we're reevaluating that reflex.
Exactly. The study comes out of the Iwai Orthopedic Hospital in Japan. The authors, Ken and colleagues, point out that while the North American Spine Society, or NASS, guidelines already give a Grade B recommendation for decompression alone in low-grade symptomatic single-level degenerative spondylolisthesis, most of that evidence is based on open or microendoscopic surgeries.
Right. The data on full endoscopic decompression, specifically the uniportal approach, is still catching up. We know FES, or full endoscopic spine surgery, offers high-resolution visualization and minimal tissue trauma. But the question remains, does the presence of that low-grade slip compromise the outcome if we don't stabilize the segment?
That's what they set out to answer. They conducted a retrospective cohort study between January 2021 and December 2022. They compared two groups of 40 patients each. Group 1 had lumbar spinal canal stenosis, or LSCS, without spondylolisthesis. Group 2 had LSCS with Myerding Grade 1 or 2 spondylolisthesis.
And just to clarify for our residents listening, Myerding Grade 1 and 2 are what we consider low grade. These are the patients where the controversy really lives. What were the primary metrics they used to define success?
They looked primarily at the Oswestry Disability Index, the ODI, and the EuroQoL 5-Dimension Questionnaire, or EQ5D. They follow these patients for 2 years postoperatively. They also performed a multivariable linear regression to adjust for potential confounding factors.
It's important they looked at the 2-year mark. With decompression alone in spondylolisthesis, the fear is always late-stage instability or a recurrence of symptoms once the patient is fully active again. Let's dive into the results. Did the Spondy group hold up?
They did remarkably well. The study found that both groups showed significant improvement in their postoperative ODI scores at the 2-year follow-up. Most importantly, when they compared the two groups, there was no significant association between the presence of spondylolisthesis and the postoperative ODI score.
So, essentially, the slip didn't matter for the functional outcome at 2 years. That's a strong endorsement for the efficacy of full endoscopic laminotomy, or FES. But I noticed in the paper that they did an exploratory analysis on the Spondy group specifically. They were looking for factors that might negatively affect the outcome in those patients. What did they find?
This was one of the most interesting parts of the paper. They found that cauda equina redundancy negatively affected the postoperative ODI improvement in the Spondy group.
Cauda equina redundancy. That's a specific imaging finding on MRI where the nerve roots appear redundant or looped superior to the level of stenosis. It's often considered a sign of chronicity or severe mechanical constriction. It's a great clinical pearl for our listeners. If you see redundancy on the pre-op MRI in a Spondy patient, you might need to manage expectations regarding the degree of functional recovery, even with a perfect decompression.
Absolutely. The authors suggest that this factor is more predictive of the outcome than the actual degree of the slip itself in this low-grade cohort.
Let's talk about the procedure itself. The paper emphasizes the uniportal nature of FES. Why is that distinction important compared to the older microendoscopic techniques?
Well, as the authors mention, advancements in camera technology and instrument development have made FES a very attractive option. Because it's uniportal and utilizes a continuous irrigation system, you get high-definition visualization of the neural elements and the ligamentum flavum. This allows for a very precise laminotomy rather than a total laminectomy. By preserving the midline structures and the contralateral facet joint, even when doing a bilateral decompression from a unilateral approach, you maintain as much structural integrity as possible.
And that's the key to avoid postoperative instability. If we can achieve an adequate decompression while leaving the stabilizing structures largely intact, the theoretical need for fusion decreases. The paper notes that FES is the least invasive endoscopic surgery, leading to reduced tissue damage, smaller incisions, and less postoperative work disability.
They also highlighted the safety profile. The study mentions that FES, including FEL, has lower perioperative and postoperative complication rates compared to conventional spine surgery. This is likely due to the superior visualization and the ability to control bleeding with the irrigation system.
It's a compelling argument, but we should address the limitations. This was a retrospective study from a single specialized center in Japan, IY Orthopedic Hospital. While they are high-volume experts, does the paper discuss the generalizability?
They do acknowledge the retrospective nature. However, the fact that they had a 2-year follow-up for all 80 patients provides a solid window into the intermediate-term stability of these patients. They concluded that FEL is an effective surgical option for LSCS, leading to significant alleviation of disability and improvements in quality of life, regardless of whether a low-grade spondylolisthesis is present.
It really supports the shift toward motion preservation, or at least fusion avoidance, in the right patient population. For a long time, the teaching was, if it's unstable, fuse it. But this paper suggests that for myodin grade 1 and 2, instability on imaging might not be as clinically significant as we once thought, provided the surgical approach is minimally invasive enough to preserve the remaining natural stabilizers.
Right. And for the residents listening, the takeaway here isn't just don't fuse. It's select the right tool. FES allows for a targeted decompression of the symptomatic level. If the patient's primary issue is neurogenic claudication or radiculopathy from the stenosis, FES addresses the pathology directly.
Exactly. And let's go back to that point about cauda-equina redundancy. In the Spondy group, that was the specific factor that hindered improvement. It suggests that in those cases, the neural damage might be more advanced or less reversible. It's a nuance that helps us in the clinic when we're consenting these patients. We can say, the endoscopy will decompress the nerves effectively, but because we see this redundancy on your MRI, your nerves may have a harder time bouncing back.
It's a great point for clinical decision-making. The study effectively argues that FEL may offer similar functional improvements regardless of the presence of low-grade spondylolisthesis, supporting its role as a less invasive alternative to fusion.
It's a step forward for the field. We're moving away from a one-size-fits-all approach of spondy equals fusion. Instead, we're seeing that if we use high-resolution, full endoscopic techniques, we can achieve great results with much less morbidity.
Before we wrap up, any final thoughts on how this changes your practice, Dr. Aris?
It reinforces the idea that we should be looking at the patient's symptoms and the specific anatomy of the stenosis. If we can reach the goal of decompression via FES, we're doing the patient a favor by avoiding the risks of fusion, like adjacent segment disease or the complications associated with hardware. This paper provides the evidence-based backup we need to offer decompression alone as a primary option for these low-grade slips.
And for me, as a fellow, it highlights the importance of mastering these endoscopic techniques. The visualization described in the paper, the ability to see the high-resolution details of the canal, really seems to be the future of how we handle degenerative disease.
Well said. I think that's a perfect place to stop. Thank you, Alara, for breaking down the data.
Thank you, Dr. Aris.
And thank you to our listeners. You can find the full paper, Full-Endoscopic Laminotomy is Effective for Lumbar Spinal Stenosis with Low-Grade Spondylolisthesis, in the 2026 volume of Neurologia medico-chirurgica. We'll see you in the next episode of the Neurosurgery Hub podcast.